Facebook, and we have broadcasted this room to all attendees. As you can see, we have attendees coming in. Thank you.
Okay. Hello, good afternoon. Okay, so it's 2 p.m. and it's a good afternoon to all. So we have a few reminders to our participants. Please post your questions to our speakers on the Q&A box. Our panelists can answer the questions on the Q&A box during the webinar. We have allotted a few minutes for open forum towards the end of the webinar, and we will be asking our speakers to respond to questions posted on the Q&A box in Facebook. All Zoom participants will be automatically muted. However, in case you experience some technical issues such as poor audio or video, please use the chat box to inform our technical staff. The webinar will be live streamed on the PhilCat Facebook page, so others who are unable to log into Zoom would still be able to watch the full webinar. And by the way, I failed to introduce myself. I am Dr. Janice Kawili, an infectious disease specialist from Makati Medical Center. I am a member of the board of the Philippine Coalition Against Tuberculosis, or PhilCat, and the Philippine Society for Microbiology and Infectious Diseases, or PSMID. I will be moderating our webinar today entitled Raising the Bar to Improve TB Testing in the Philippines. This webinar was organized by PhilCat in coordination with the National TB Reference Laboratory, USAID TB Innovations and Health System Strengthening of FHI 360, the Interactive Research and Development, and the Philippine Private Sector Diagnostic Consortium. And may I ask for the objectives of the webinar to be posted? Okay, so here are session objectives. To understand the current country situation, roadmap, and policy directions to improve TB testing, especially in the time of the COVID-19 pandemic. To learn international experience on innovative approaches for specimen transport and laboratory connectivity and models that can be implemented in the country. To understand the importance of establishing a consortium in improving access to GeneXpert MTB-RIF and GeneXpert Ultra in the private sector, and to learn from the experience of high TB burden countries with low HIV cases in the region and how these countries scaled up GeneXpert for TB testing. To start the webinar session, let me introduce Dr. Clotilde Howe. Dr. Howe holds the distinction of Professor Emeritus of the College of Medicine, University of the Philippines, Manila, where she taught in the Department of Pharmacology for many years. She is a recipient of the Dr. Paulo Campos Award for Health Research, awarded by the Philippine Association for the Advancement of Science and Technology for her work on prevention and treatment of childhood tuberculosis. She is currently the National Chair of PhilCat. May I call on Dr. Clotilde Howe for her opening remarks. Thank you.
Hello, good afternoon. Thank you, Janice. I would like, on behalf of PhilCat, I would like to welcome everybody, our special guests, panelists, and those who are participating in this webinar. As you know, this is the fourth of our series of webinars to celebrate Lung Month. At the same time, please take note that August 19 is also the birth anniversary of Manuel L. Quezon, who was the president of the Philippine Commonwealth. He said these words: "This experience has convinced me that TB is curable and that anybody at the incipient stage of the disease with the means and the willpower to get well can be cured." He said this in 1938. I think this was still before the dawn. This was the dawn of chemotherapy for TB, and he passed away in 1944. At the time, I think we already had streptomycin, but his optimistic words really reflect the progress that has gone on with anti-TB chemotherapy at present. Now, the title of this webinar says Raising the Bar, and it applies also to what we're doing now in the COVID control of COVID, because even if we're back to what do you call this? I get confused. Community quarantine. Raising the bar means that we are going to improve our compliance to prevent COVID. So let me now welcome you again and wish you a good afternoon. Thank you.
Thank you, Dr. Howe. And thank you also for continuing to inspire all of us working in TB. So yeah, Dr. Howe wanted a series of webinars, and this is the reason why we are having these webinars for August. So maybe we can proceed to our next slide. Kindly, okay, there. So we have 4 speakers this afternoon, and we remind our speakers to please turn on your video when it's your time to give your talk, so our participants can also see you. Our first speaker graduated from the College of Medicine of the University of the Philippines, Manila. He pursued a career in public health and served as a programmatic management of drug-resistant TB or PMDT, medical specialist, treatment center physician, and operations coordinator. He is currently the head of the National TB Reference Laboratory at the Research Institute of Tropical Medicine to discuss the Philippine situation roadmap and policy directions to improve TB testing in the country. Please welcome Dr. Ramon Basilio. Mon,
Thank
can
you,
start.
Dr. Anis. Thank you. Good afternoon. I'll start to share my slides. Thank you. Can everybody see my slides? Is it up?
Yes, we can see
Yes,
your slide,
thank you.
but maybe you can use the slideshow mode.
Okay, there you go.
Yeah,
So good
better.
afternoon, everybody. So I've been tasked to talk about the first topic, which is, are we testing enough? So before that, I'd like to thank PhilCat. I'd like to thank FHI 360 for inviting me to give this particular talk now. So if we go to, are we testing enough as a question, we have to go also to where we were, where we are now, and where are we headed. So if we look into the Philippine estimates of TB burden in 2018, and this was published in the WHO Global TB Report of 2019, our total TB incidence is around 591,000 in total numbers, which gives us a rate of around 554 per 100,000. So given this, our total TB case notifications, so we have a total in new and relapse of around 371,000 and total cases notified of around 382,543. And if you look at tested with rapid diagnostics at time of diagnosis, 36% may not be that high, but if we look into the history of how we got here of using rapid diagnostics since the time that we introduced it in 2011, 36% is quite high already, given that we started using GeneXpert only for a particular subset of patients. And if you look at TB treatment coverage comparing 2017 and 2018, we have already improved by a big number already of around 8%. So at 55% in 2017, we have increased to 63% to 2018. So this is our TB treatment coverage of notified over estimated incidence. And if you look at the graph that I have posted here, though, it looks like we have really had an increasing trend of notification from 2009 up to 2018. The black line represents the new and relapsed TB cases notified. And if you look at the green line, which is total TB incidence, before we actually lower that TB incidence, our notifications really need to reach that line to approach it. So we were on the right track given the circumstances between 2018 and 2019. And also, we have a robust policy environment for increasing TB testing, as evidenced by examples here, which are the three examples are the TB Laboratory Network Strategic Plan of 2018 to 22. So this is a sub-plan that we created, and it was called out from the original Phil Step 1. And we took the very salient points and important points that are very particular for the TB Laboratory Network and the laboratory itself. Of course, we have the updated Philippine Strategic TB Elimination Plan, which was updated last year due to the updating of the joint program or the conduct of the joint program review. And of course, to implement all these policies, we have the Manual of Procedures, the 6th Manual of Procedures, which was completed this year. So this is actually a good cycle and a good policy framework wherein policies were created in order to increase TB testing, and how to implement this, even at the lowest level, is through the Manual of Procedures. So going through each policy framework, for expansion, for the Laboratory Network Stat Plan or the LNSP, it really focuses on 4 objectives, mainly expansion and accessibility, service delivery, of course, quality. We cannot remove quality from any laboratory and laboratory network. And of course, the information that we use, that information must also provide some input to our policies and directions. So going forward to the LNSP, the first objective is to improve access to quality assured TB and DRTB diagnostic services. And it calls for increasing availability and accessibility to the WRDs to strengthen the implementation of the specimen referral and transport system, and also to expand the private sector engagement for TB laboratories. Number 2 would be to ensure the continuous availability of TB diagnostic services and to ensure that operations continue. And number 3, of course, is quality, to develop and maintain a quality management system for all TB laboratories, and to improve TB laboratory biosafety, biosecurity, and waste management. And for information is to improve the utilization of TB lab info and conduct of TB research, and to improve the information and data management systems, to strengthen MSC or monitoring, supervision, and evaluation of TB labs, and to develop the operational research capacity at the level of the regional levels. And if we go forward to the fifth step, the updated fifth step, we want to reduce TB burden by decreasing the number of TB deaths by 15%, to decrease the TB incidence rate by 12%, and to reduce catastrophic costs incurred by TB-affected households to 0%, and at least 90% of patients are satisfied with TB services. Now, there are also updated testing and diagnosis strategies within the updated fifth step, which includes the compliance to mandatory notification, the rapid diagnostic test expansion and utilization, wherein it was called out to simplify the diagnostic algorithm and expand additional RTDLs, enhancement of the referral network, and to implement a diagnostic connectivity solution. Line probe assay and drug susceptibility testing optimization, and improve the quality of clinical diagnosis. And even in the MOP, wherein this is the implementing policies or at the grassroots level, number 1 policy that I highlighted here is that number 1, a rapid TB diagnostic test such as Expert MTB-RIF shall be the primary diagnostic tool or test for PTB and EPTB in adults and children. And all of these policies point out towards increasing our testing, increasing those who have been screened, and also towards notification. So where were we in 2018 and 2019? So this is just a table that shows our accomplishments towards testing. And if you look at the total cases examined, so these are the tested in both DSSM and expert. In 2018, we tested around 1.1 million patients. And in 2019, there was a slight decrease to around 1.08 million. But if you look towards expert MTB-RIF, it increased from 460,000 to 472,000. Given that in 2019, I think we experienced a shortage of MTB-RIF cartridges at the time, but we picked up tremendously because of our efforts to test everybody using expert. And I'd like to introduce this population testing rate. So this is the percent of the population in a given area that was tested using DSSM or expert. So for the whole country, we were at around 1%, but our target is above 2%. And our expert utilization, it decreased from 2018 to 2019, but this is given because we increased the number of RTDLs or the rapid TB diagnostic labs between those years. And also still, we increased our expert MTB-RIF cartridge consumption. So let's look at Q1 of 2020. If you look at Q1 2020, our cases examined was around 300,000 already. So if you multiply that by 4, we would be hitting closely 1.2 million tested. And because we were rolling out, or we are rolling out the new policies for TB testing, this was projected to be to increase more. And look at our expert utilization. We already hit 7 per machine per day, which is already an achievement in our program. But then this happened. So I'd like to share this blurred out picture. This is a blurred out picture of what we call in NTRL as our coloring book. This is actually a worksheet that we have for RT-PCR for COVID-19. And we call this a coloring book because each highlighted cell in this worksheet corresponds to a positive COVID patient. And this is very memorable for me because this worksheet actually is has the highest positivity among all the worksheets that we've released over the past few months. So this is actually 33 positives over 90 that were tested. So this happened right now, and this is happening right now. And so what has been the effect of it for Q2 of 2020? And we have seen that it has tremendously decreased our total cases examined. So from 298,000 in Q1, we are less than 100,000 in Q2. And there have been decreases across the board in terms of the number of cases with positive results, our population testing rate, our average expert utilization. It has gone down. So what needs to be done with regards to this is that we have to adapt. We have to adapt to the situation of COVID. We have to translate what we have already established as policies and to create the NTP adaptive plan in order for us to still implement what we need to implement throughout the coming months to achieve our targets. And this is the fruit of the discussions, which is the NTP adaptive plan. And I'll just go through some of the salient points related to testing and diagnosis within the NTP adaptive plan. So number 1, of course, is our standard precautions with TB specimens. And of course, these are general precautions of proper hand hygiene, physical distancing, decontamination and disposal procedures, wearing of proper PPE. On sputum collection shall be done by the patient at home, and specific instructions should be given to the patient by the healthcare worker. And if not at home, and if the patient will need to go to the healthcare center, collection shall be done in an open, well-ventilated space with appropriate PPE, with the patient at a safe distance, and the direction of the airflow is from the healthcare worker to the patient. And of course, TB testing shall be done and referred to the TML or the RTDL, wherein there should be a complete set of PPE available. And if the patient is a confirmed COVID-19 case, the specimen of TB shall be referred to a laboratory compliant to at least BSL-2 standards. And if complete set of PPE is not available, the specimen shall be sent to the nearest laboratory where the complete set of PPE is available. This is also the time to remind the facilities that there are minimum requirements in performing expert on the benchtop. So such as absorbent lining, we need to take note of the adequate ventilation, the personal protective equipment. Staff needs to have sufficient training. And of course, the same turnaround time must be observed, and there should be a verified infectious waste disposal program within the laboratory. We also reminded facilities that there should be a unilateral flow from dirty to clean activities in setting up the laboratory. So from the dirty side, when receiving the specimen, to using your gene expert, towards recording and reporting. So from dirty to clean. And these are just some examples of the recommended PPE for the facilities and for the specimen transporter. So for the specimen transporter, minimum would be a surgical mask and gloves. Of course, we need to have our hand sanitizers ready, our alcohol ready, frequent hand washing. And for laboratory staff, your head cover, your face shield, your properly fit tested respirator. Let me take note, properly fit tested respirator, your gown, and your gloves. So in summary, we were on the right track. We have the policies in place to increase testing, screening, and notification. You know, testing is just one aspect of TB. Of course, we need to increase the screening, meaning the number of patients that will be tested eventually. And there should always be mechanisms in place to notify these diagnosed cases. We are on the track to increase testing, but resources and priorities have shifted to the pandemic response. Case in point, the National TB Reference Lab, we have been testing COVID cases since May 9, 2020. We are actually testing recently, around 1,200 to 1,440 every day. So that has been our load daily, and this is on top of what we have been doing for the TB laboratory network. And so we need to adapt to the changes using the NTP adaptive plan, and we need to continue the work to end TB. Thank you, everybody, and have a good afternoon.
Okay, thank you, Mon, for your presentation. It was comprehensive. I'm sure there will be more questions. A few questions have been posted on the Q&A box, and please feel free to answer these questions. But we will now proceed to our second speaker. May I have the slide, please, for the second speaker? Okay. Our second speaker is Kamiko Nichols. She's an independent consultant with technical expertise on specimen referrals. She has spent the past 13 years assessing, designing, and implementing and evaluating specimen referral networks subnationally and nationally across over 20 countries in sub-Saharan Africa and Southeast Asia. She has worked on systems across HIV, TB, diseases under surveillance and outbreaks, working toward integration and harmonization. To share information on specimen referrals across countries, she developed a freely available specimen referral toolkit for the Global Laboratory Initiative, or known as the GLI. Please welcome Kamiko Nichols, who is now in France, to discuss innovative approaches for specimen transport and laboratory connectivity in TB. Okay.
Thank you very much, Dr. Janice. Thank you very much. And thank you to PhilCat for having me present today, and thank you to FHI 360 for the invitation. Just bringing up my slides now, and hopefully
it's there,
coming through. Okay, great. Thank you very much. And today I will be talking about bridging patients to rapid TB testing, and specifically focusing in on specimen referrals and the diagnostic network. I'll be discussing learnings from other countries. If we think about how patients can be bridged to rapid TB testing, we need to first consider the availability of testing capacity, which Dr. Basilio just discussed in his presentation. And then we also need to think about patients' ability to access that testing capacity. So the rapid TB testing capacity is made available through the TB Diagnostic Network. And one way that accessibility is made available is through the TB Diagnostic Network, is through either on-site testing, but also through referrals, either through patient referrals or specimen referrals. And today we'll be focusing on specimen referrals. So if we look at the overall diagnostics network, which you see in blue, it's comprised of many different components. We have data systems and connectivity. We have various testing platforms and other components of the laboratory, such as equipment management and biosafety and waste management. And then we also have specimen referrals as a component of the overall diagnostics network. And then if you look at this section in green, that looks at the components then of the specimen referral network. Specimen referral network is made up of various components such as finances, HR and training, supplies and equipment, transport, etc. So how the diagnostics network is designed and set up, for example, where equipment is placed, where testing capacity exists, what the testing algorithms are in country, that directly impacts how the specimen referral network will be designed. So discussing more specifically about specimen referral networks, there are 5 main goals of providing this type of service. One is to increase access to off-site testing. 2 is to ensure timeliness, both of testing and return of results. 3 is to ensure biosafety and biosecurity throughout the entire process. 4 is to improve the quality of testing by ensuring specimen quality, especially during transport and referral. And 5 is to increase the cost efficiency of diagnosis. If we look at the various components of specimen referral, there are a lot of challenges across all the components. These systems are complex and there are many challenges. Just to highlight a couple of the challenges in a couple of these different components, there is generally, although it was very nice to see in the Philippines that there is a policy in place, but many countries do not have a policy or guidelines in place that's specific to that country. Also, there can be a lack of coordination and communication among stakeholders. These systems generally are very heavily funded by donors, which brings into question sustainability of these systems. Specimen referral design is not always clearly planned out. The transport schedules and the routing, they're not always documented and they're not always very widely shared. With training, there's not always enough training on some of the data systems and monitoring and evaluation that's necessary for specimen referrals. There is sometimes a lack of the availability of packaging supplies, especially the secondary packaging. And in terms of data systems and M&E, we will come back to this because there are a lot of challenges around obtaining quality data around specifically for specimen referrals. So in the assessments that have been done across many countries, there are generally a couple of recurring recommendations. So one of those recurring recommendations is to really start with establishing a technical working group that focuses on specimen referrals specifically. And this should be an offshoot of an existing technical working group that focuses on the diagnostic network or that focuses on a specific disease. And the specimen referral technical working group should have a focal point and should be able to coordinate all the various stakeholder activities and provide communication. This group, of course, should meet regularly and should actually discuss the progress of the specimen referral systems across the country and discuss performance. They can provide technical advisory on guidelines, on training materials, on data collection tools, and they should look to establish roles and responsibilities across the entire specimen referral network. The second key recommendation that we see across countries is around the guidelines. So again, Dr. Basilio had already mentioned that a specimen referral policy was approved, and many countries do not yet have this. So the general recommendation is that specimen referral guidelines should be in place for all specimen types and for all diseases. So the specimen referral guideline should cover as many diseases as possible, any diseases that have specimen referrals as a component. And in order to do these guidelines and develop these guidelines, generally country needs to go through a landscape assessment first to understand what specimen referral systems and how the network performs across the country. And I won't go too much into the differences between the guidelines and handbook from the laboratory and other laboratory documents, because Dr. Basilio explained those in the Philippines, and it sounds like you have different documents already for these different purposes. The third recommendation is all around data systems and data availability. So it's very difficult to know whether or not we're meeting those 5 goals that I mentioned previously, unless we're able to actually monitor those goals. And we have indicators to track those specific goals. Most countries have difficulty understanding whether or not their specimen referral systems and network are performing well. And it's important that these M&E frameworks and data systems are considered before the system is actually put in place and not considered just as an afterthought. The country needs to think through very closely what role data plays and how visibility of this data can help improve the overall systems and network. For example, how will specimens and results be tracked through the entire system? It's very difficult to track individual specimens, as you may know, and so that needs to be thought through. What data is available at the facilities, at the laboratories, what costs and cost information is available. Those types of information can be difficult to obtain. So there are a lot of challenges around data. Also, as I mentioned before, there should be a stakeholder group that reviews the progress and the performance of the overall network. And even though there are a lot of challenges, there are opportunities of improvement. And there are innovations that are around data connectivity, connecting various different laboratory equipment to an electronic system, and allowing some of the data to be entered, allowing the specimen to be entered into these data systems as soon as they're collected, and allowing then that specimen to be tracked throughout the entire turnaround, including when the result is sent back. So the good news is that there are ways to improve this area of data. And there are global resources that are available. So as Dr. Janice was mentioning, through GLI, there is a guide that helps countries think through generally what should be included in guidelines for specimen referrals. And this is not only limited to TB, but also looks at integrated networks. And there's also the toolkit that has a lot of resources on specimen referrals. So hopefully you're familiar with these already, or if not, this is the information of how to find them. So now getting into some of the country examples. So across many countries, there's a lot of activity right now to strengthen specimen referral systems. And there has been a lot of activity, especially in the last 5 years. So a lot of countries are focusing on integration, and integration can mean a lot of different things, but these are some examples of integration on various different components of the specimen referral system. Some countries are integrating their guidelines. So again, having guidelines that are not disease specific or specimen type specific. And those guidelines also including integrated M&E frameworks. There are also countries that are integrating their technical working groups for specimen referrals, such as Mozambique or Burkina Faso. There are countries that are harmonizing and looking for synergies across disease programs and specimen types beyond just HIV and TB. So looking at integrating the transportation of various, a number of different diseases, not just between HIV and TB. And some of these countries are countries also with lower HIV prevalence. Countries that are mapping and assessing the overall diagnostics network, not just focusing on one disease. And again, with transportation, maybe taking one disease program specimen referral system and leveraging that to transport another disease program specimens. An example specifically in one country is in Burkina Faso. So Burkina Faso in West Africa started out with doing an assessment of their specimen referral network. And this looked at various programs. It looked at programs under their disease control program, such as meningitis, also under their vaccine preventable diseases program, and as well as HIV and TB. So all of these diseases, there was data collected on where the collection and delivery points were, what type of transport was used, what the costs were for those systems, the frequencies, etc. And also other logistics systems and providers were explored, such as the Central Medical Store and the National Postal System, to see whether or not anything that they were doing could be leveraged for specimen referrals. And these assessments actually happened all across primarily West Africa. Burkina Faso then used this information to design a surveillance system that was initially used just for one specimen type and for one disease. And this included the transport of specimens from 4 districts to the testing facility. And the National Postal Service was chosen as the transport and logistics provider, which is common in other countries, such as India has just signed an agreement with the National Postal Service to transport specimens. And part of the negotiations with the contract included key performance indicators that were included in the contract. So there were a number of key performance indicators that were agreed upon that the Postal Service would meet. And this system then began in 2017 with one disease and 4 districts. And by the end of January of this year, the country is looking to fully scale the system nationally and integrate it with 8 total disease programs. One of the challenges with this system is it's because there are so many different disease programs involved, is how do they all pool the money that they have available to pay for this one system. There were also examples in West Africa during and after the Ebola outbreak. So in Liberia, Sierra Leone, and Guinea, before Ebola, we saw very weak laboratory networks and specimen referral systems. But during the Ebola outbreak, the laboratory systems were strengthened as well as specimen referral systems were created. Post-Ebola, the countries were looking to build off of these strengthened systems and also sustain the specimen referral systems that were designed. And Guinea recently, last year, published a journal article documenting this experience. Mozambique and Southern Africa also looked at whether or not the management of specimen referrals could be done using other logistics expertise from the supply chain side. So there was a project created in 2018 that was USAID funded, and it used one logistics provider to manage both specimen referrals and distribution of commodities. And some of the benefits of using this logistics provider, which is a very large commercial company, is that they had systems in place such as a vehicle tracking system and such as real-time delivery confirmation. And those were then used also for the specimen referral system. In Malawi, also in Southern Africa, there was a transport analysis that was performed, and it looked at what would happen if a new form of transportation, which was drones or UAVs, was introduced into the overall network, and how that would affect coverage and costs. And then also additionally, whether or not excess capacity in the drones could be utilized by other programs to carry other types of health cargo, such as vaccines or blood for transfusion. And I will end with talking a little bit about what we are seeing currently and into the future. So one very popular topic or activity or exercise that's being done now in many specimen referral networks and diagnostic networks across multiple countries is diagnostic network optimization exercises and design exercises. So these have been ongoing in many countries, including the Philippines, which you might be familiar with. These optimization exercises begin with mapping and spatial analysis using GIS, and then it layers on data of current and future testing demand for either one disease program or multiple. And then scenarios are chosen based on what the country would like to understand or explore. And then models are put together using computer software. And eventually a country can choose a scenario and then design the future diagnostic network. And since, as we started out and saw in the slides, the specimen referral network is part of the overall diagnostic network, it is included in the analysis. So this includes what types of facilities, laboratories, or collection facilities, what linkages there are for referrals, which facility refers to which laboratory, the frequencies and the routing, etc. And it's very important in these exercises to understand what the country wants to answer and what the country would like out of the exercise. And then also to monitor whether or not the recommendations are implemented. And then finally, we talk a lot about integration, and I mentioned this previously, but integration is not the only way to improve efficiency. There are other ways also. So I mentioned before, consolidating the management of specimen referrals and distribution of commodities or other logistics functions and outsourcing that to logistics experts. So I mentioned that in the project in Mozambique. Also, that is being done in Nigeria in another project. Another way is to look at specimen transport being both on demand and also having a scheduled service to save funds. And there are countries that are looking at that. Also using apps such as an app similar to Uber that can match transport supply and demand. And then going even further beyond diagnostic network optimization exercises and looking specifically at optimizing the route network of specimen transportation. But it's important to also say that innovations can improve access and equity, but they might not be cost efficient. And so I've listed a paper here that's looking at what should be delivered by drones and whether or not that would be cost efficient. Thank you very much.
Okay, thank you, Kamiko, for that insightful discussion. And there are actually a few questions for you already on the Q&A box. And we hope you can answer them, but later we'll have open forum. Hopefully we'll have time for the open forum. So we can proceed now to our next speaker. Okay, thank you. Dr. Lalaine Mortera is a pulmonologist by profession. She completed her residency in internal medicine and pulmonary medicine fellowship at the University of the Philippines, Philippine General Hospital. She led the task force for the Philippine Clinical Practice Guidelines on the diagnosis and treatment of TB in adults when she was the national chair of PhilCat in 2017. She's a member of the board of the American College of Chest Physicians, Philippine delegation. Dr. Mortera is currently the private sector advisor of the USAID's TB Innovations and Health Systems Strengthening Project to discuss establishing a consortium to improve access to GeneXpert, MTBRIF, and Ultra in the private sector. Please welcome Dr. Lalaine Mortera. Lalaine, you can proceed with your lecture.
Good afternoon, Janice, and thank you for the kind introduction. It's quite gloomy from where I am staying, so it's kind of strong downpour outside. So hopefully my Wi-Fi will not conk on me. Anyway, a good afternoon or good morning for those who are watching from another time zone. My topic for this afternoon is about market-based model for pool procurement and uniform pricing for the private sector. This is something, this is a innovation that we have recently implemented in the Philippines. And I would like to talk about it later. But before I proceed, I would just like to have a poll. Okay. So I will give you 30 seconds to answer this very simple question. If you have requested GeneXpert, MTBRIF in the past 6 months, you can say yes or no, or you cannot remember, or you're not familiar with the GeneXpert, MTBRIF. Okay, thank you. You can just end the poll. So we have about 50% have requested GeneXpert for the past 6 months, and 48% were not able to request for one. At least only one is not familiar with GeneXpert. At least it will tell us how much the promotion of the GeneXpert in the Philippines would look like. Okay, can you pull up the second poll question, please? The next poll question, please.
Okay, Lalaine, okay.
Yeah, so can you show the second poll question?
Maybe we should stop sharing that.
Okay, this is a better question that I would like to know your answer. How much does the GeneXpert MTBRIF test cost in the private sector? At least for the last time you requested for the test. Is it 10,000 and above? This is in pesos. So our current exchange rate is actually down 48 pesos for a dollar now, 48 to 49. So is it 7,000 pesos but less than 10? Is it 5,000 to 7,000? Is it less than 5,000? Is it less than 3,000 or I do not know. Okay, can we please end the poll? Okay, so it's actually like most of you answered about 10 and above, 7 and above 5, and only few actually answered less than 5,000 and 3,000. Of course, if we refer to the public facilities, it's free. Okay, so I will now proceed with my presentation, and requesting for remote control. Okay. So there's a little lag, no? So Dr. Juan Basilio actually shared with you the gravity of TB in the Philippines. It is really a big public health in the Philippines. And based on the 2016 National Prevalence Survey, we know that 1 million Filipinos will have active TB. That's about 1% of the population. In terms of ranking, the Philippines is 4th globally. Next to, of course, India, and then China and Indonesia. So we are contributing 16% of the global burden. In terms of mortality, about 3 Filipinos die of TB every hour. And for those who are accessing services in the public sector, although tests may be free, but they actually experience also some catastrophic costs, which is about 30%. And when we define catastrophic cost, it's actually spending 20% of the annual household income for TB alone. So this is the response of the government of the Philippines. How are we going to address this? And we have to do it the business not as usual. And of course, when we say business not as usual, the Philippines has committed to be able to contribute to the Stop TB targets. The NTB targets would be to find and treat 2.5 Filipinos with TB by 2022. And Secretary Duque actually mentioned 4 key strategies, which are finding missing cases, rolling out massively about rapid TB testing using GeneXpert in the public facilities. Of course, they need to increase treatment adherence. And the 4th one, the major one, is the mandatory TB notification in order as a form of engagement of the private sector. So if you talk about this business not as usual response, the first aim is really to roll out the massive rapid TB testing. But for us to find 2.5 billion Filipinos, we have to do testing, which is about 14 million to be able to do this. And if you look at the current capacity of the Philippines, there are already 488 facilities with a GeneXpert, but among these, only 4% or about 20 are in the private sector. So if you look at the demand, the anticipated demand, and the availability of resources, I'm sure that we still need to engage more facilities to have the GeneXpert machine, or we need the private sector engagement to be able to at least provide and be able to respond to a certain market share of this TB testing. So currently, what is the status of GeneXpert in the Philippines? Based on the Lancet 2018 publication, we are the 2nd highest globally in terms of the cost of GeneXpert in the private sector, for about an average of about $155,000. In pesos, that is about 7,500. If you talk about the current status of engaging the private sector to be able to contribute to the TB targets, we know that at least 1 of 3 would prefer to consult a private provider for many reasons, probably because of convenience, they value time, more rapid turnaround time, or probably because of the distance. Another status of engaging the private sector is the fact that for those who decide to consult the private sector, they incur actually a 70% catastrophic cost compared to those who go to the public sector. And this is very much significant. Third, important data, if we are, I've mentioned earlier, to find 2.5 million patients to be started on treatment, we have to do 14 million testing. And therefore, for those who would prefer to seek consult in the private sector, we need to really engage them so that we will be able to do at least point of care testing where patients actually prefer to consult. And lastly, unfortunately, we do see also a lot of TB patients, but because of access issues or probably because of cost issues, we tend to start treatment anyway without bacteriologic testing. And this practice is actually kind of dangerous because we might be overdiagnosing TB, and worse, we might be missing drug-resistant TB and maybe started on the usual regimen for drug-susceptible TB patients. So this is what we want to actually introduce, innovations to be able to address these challenges. And that's why we were able to establish the Philippine Private Sector Diagnostic Consortium as a response for this issue in the private sector. So the consortium, with the tagline, providing quality diagnostics within your reach, we hope that this will be a national platform so that we'll be able to encourage the key stakeholders who are actually influential in terms of private diagnostic testing. We would like also to be able to mitigate this high cost and negotiate for better pricing. We call concessional pricing, but we can only do this with pool procurement, what we call as high volume, low price strategy. So if we'll be able to come up with the volume, we will probably be able to have a better bargaining capability to negotiate for a discounted or a concessional pricing. And of course, we have the vision to increase access and utilization if we are to contribute to the TB targets laid out in the PhilSTEP. So how did we come up with the consortium? Actually, it was a very long journey. A lot of mindset change, a lot of backdoor discussions, and a lot of convincing. So we started in February 28 when we had this consultative meeting, and we invited key stakeholders, laboratory networks, providers, and including suppliers. And there was a common vision. Let's put down the price if you want to test more Filipinos. And because of this common vision, we started to look at how we will do this. And of course, we were able to have a consortium charter, which was ratified in May last year. And there was a general understanding on how to move forward so that this concessional pricing will actually read down to the patient, to our clients who will better afford this test. So fortunately, it was launched last February 26, just this year. And unfortunately, after the launch, we already had the COVID pandemic. So as much as we wanted to push for aggressive marketing and expansion of membership, we had to contend with the limitations of the COVID pandemic. But this is now the good news for everyone, and especially for our listening audience. The cost has now been reduced from the second highest globally to becoming the third cheapest. And this is a feat that we are very proud of. We were able to reduce the price to as low as 70%. So the uniform pricing to the consortium, if you are going to have your patients or your clients tested in a consortium member laboratory or hospital, it is a uniform charging of 2,268 pesos. So what are the requirements or the agreements or the conditions to be a member of the consortium? Of course, a consortium member should agree to a uniform pricing that is agreed upon for the consortium. Second, members should continue to provide quality services, meaning they follow quality assured practices. They are a licensed laboratory. They have the certification, appropriate certification to offer services. And a third very important requirement is if they do have some positive tests, this should be reported to the National TB program. So it gets it is now a contribution. It's a contribution to the National TB program and eventually to the PhilSTEP targets of the country. And the fourth, they need to be they understand that they will be monitored in terms of the compliance to pricing and all these notifications. So what are the requirements? Very simple. Assigned membership application form, the certificate from the OH. So these are all the documentary requirements, which are easy to produce if someone is doing some legitimate business in diagnostic testing. And of course, after the laboratory or hospital submits this to PhilCat, then I've shown here the email address. If you are interested, then members will be able to be oriented on how they will be submitting or processing their membership. Now, for the consortium, we have these founding consortium pillars. Of course, PhilCat, who accepted the challenge to be the convening agency and the secretariat, and currently the automatic chair of the governing council of the consortium. We have CIFID as the first supplier to join the platform of the consortium. CIFID is the diagnostic manufacturer for GeneXpert systems. We have Macare, the local distributor and service provider for GeneXpert systems. We also have the PPPI, partner for pool procurement for other goods beyond GeneXpert. And of course, technical support that is provided by USAID, the Interactive Research and Development, or IRD, and of course, the FHI 360, which is implementing the TB Innovations and Health Systems Strengthening Project in the Philippines. So these are the initial pioneering members who already have procured through the consortium. And we are proud that there are 11 private hospitals and laboratory networks, and they're located predominantly in NCR, some in Region 4A, one in Ilocos, Region 1, and one in Region 7, Bohol. And we also have additional members, there are 4, who have yet to procure or decide what exactly will their participation is in the consortium. So this is the journey of our engagement with the consortium members since launching, which was done in February 26. We did some online training on GeneXpert, both the MTB and the Ultra last April, and it was a challenge because it was during the COVID pandemic, so we had to do it online. And the first full procurement was delivered and installed during the month of May, where most of our founding members started operations. We had the proficiency assessment that was facilitated by the consortium, of course, in coordination with the NTRL in the month of June. And the past July, we oriented them on the existing integrated TB information system, or ITIS, and they were oriented on the new recording forms of the National TB program to enable them to report or share their data with the program. And of course, this is today, August 19, 2020, where we would like to publicly announce that the consortium is running and ready to accept new members. And then hopefully we'll be able to receive the second procurement this towards the end of August. And also the election of the governing council for this, for the second year. So just to give you a snapshot of the consortium members that we now have, we have the High Precision, which actually started their operations just this May 14, 2020. They have passed the assessment, proficiency assessment, and to date already have run 278 tests, a 17% positivity rate detecting TB, with an 8% detection of RRTB and about 2% of trace results. We also have Chinese General Hospital, which as of July 24, just a few months of operation, they started May 16, they already have about 73 tests done. and they also passed the proficiency assessment. The third member I would like to share is actually Manila Medical Center Manila, or Manila Med. They also started the operations May 18. They already tested 47 specimens, and the detection rate for positive is 11%. So this is despite the COVID pandemic. They were able to offer TB testing despite the limited travel and many precautions in terms of the travel restrictions. And of course, we have the fourth, the latest who started the operations June 4, and they already have tested 55 as of August 15, with a positivity rate of about 13%. Also, they passed the proficiency assessment done last July. So there are more that are coming, and hopefully we'll be able to provide the technical assistance to future consortium members who are going to procure through the consortium. And we actually received this latest feature, and I'm very excited and very much happy that across the FHI network globally, it was featured in the latest impact study last year about the consortium as an innovation, reducing pricing of about 70%. So what are the next steps for the consortium? We hope that with the wide dissemination of the manual of procedures that was just recently released and later will be launched this afternoon, making GNS Expert as the primary diagnostic test, hopefully utilization will increase. We hope to expand the membership nationwide, so we are prepared to receive your queries if you want to be a member. There's an ongoing MOU with the Department of Health and a future anticipated release of a department memo to endorse the consortium to other regions. And hopefully we can share the experience that we have to the consortium, because in the Philippines, it is the consortium that is offering it initially. And of course, we would like to pilot a laboratory notification module, a paperless at that, through the consortium, and eventually expand to other TB tests and non-TB tests. So at this juncture, I would like to share a video about the advocacy, and you can share this. This is developed by FHI to support the consortium. So here it is.
Tuberculosis is curable. Yet globally, TB kills more than any other infectious diseases combined. About 3 Filipinos die of TB every hour. Early accurate diagnosis is the first step to eliminate this public health disease.
With this, we are confident and hopeful that we can find and treat at least 2.5 million Filipino patients with TB.
The World Health Organization reports that despite free TB diagnosis and treatment in public health facilities, about 35% of people with TB faced catastrophic costs or expenses beyond their means. This could even go up to 70% for those seeking care in the private sector.
Ako si Mildred Pancho, isang TB survivor. So, pinili ko na pumunta dati sa isang private service provider kasi that time nung gagamot ako, mas malapit siya sa bahay namin. And at the same time, I can still get the quality service at I can know kung positive ba ako or hindi sa TB, even if it means that I have to pay for that service.
1 out of 3 Filipinos with TB symptoms prefer to seek initial care from the private sector for many reasons. So we should find ways to make these services more affordable to reduce out-of-pocket costs for TB care.
We established the Philippine Private Sector Diagnostics Consortium among private health professionals, laboratories, and hospitals as a market-driven model to ensure concessional pricing for WHO-recommended tests for TB and other public health diseases.
Consortium members are committed to offer these tests at a much lower cost. We started with the globally recommended Gene Expert test to reduce its price in the private sector by as much as 70%.
The consortium is a concrete example of private sector engagement in our Philippine Strategic TB Elimination Plan. It helps keep the costs down, connect experts, create a community of practice that brings advanced diagnostic technologies within reach of Filipinos.
For private hospitals and laboratories, we encourage you to join the consortium, a game-changing initiative. Together, we can ensure utilization of WHO-recommended diagnostic tools for TB and non-TB tests for our patients, contributing significantly to public health targets and therefore better health outcomes.
Let us help the Filipinos who want to be diagnosed early for TB. Be among the private diagnostic facilities with the seal of the consortium where tests are fast, accurate, affordable, and of quality.
Join the consortium.
Join the consortium.
Join the consortium.
So with that, thank you very much and good afternoon.
Thank you, Elaine, for your talk and for that video. We hope that more private institutions will participate in the consortium, and we really look forward to more private hospitals doing GeneXpert tests for patients at a lower cost. There are also a few questions for you on the Q&A box, and please feel free to answer these questions. We will now proceed to our fourth speaker for this webinar. Our fourth speaker is Ines Horman, and she's joining us all the way from Germany. She's a microbiologist and a visiting scientist of the European Commission. She's currently the product manager for tuberculosis for Cepheid, handling Europe, the Middle East, and Africa. For the past 8 years, she participated in several NTB initiatives in the field of R&D to product management. At Cepheid, she's involved in the rollout of Expert MTB-RIF Ultra and Expert MTB XDR. May I call on Ines Horman to share with us her experience working with countries with high TB burden and low HIV cases to scale up GeneXpert testing.
Thank you so much for the kind introduction, as well as for inviting me to share some insights. Okay, in my presentation, just a high-level overview, I would like to share some insights on where we stand today with the rollout of MTB-RIF. Then I will do a little recap on the new MTB-RIF Ultra test. We will look together on the implementation guide, and I'm guiding you through some external resources to support the implementation. So we are here today to talk about the global biggest infectious killer. And as we learned already from the previous speakers, drug-resistant TB is really a critical element, and the appropriate diagnosis is today, in particular under COVID era, more and more important to avoid spreading disease. So we have ambitious targets to end TB. The United Nations Sustainable Development Goals are really setting ambitious targets, and even under a COVID situation, these are even more ambitious to end TB by 2035. So what is needed to help us to achieve these global goals? It's really to make sure we are declining as rapidly as possible the global TB incidence rate by using or optimizing the curing tools. That means to roll out and to engage with the private sector to do TB testing on a point of care level, as well as to use novel tools and really rapidly implement them as early as possible. So why is this so important? When we look on the route of TB transmission, for us, it's quite important that we are identifying those transmitting the disease with active TB, where the bacilli are living and growing and the patient shows symptoms. We are identifying those as early as possible to interrupt the chain of TB transmission. And this is just possible by using an accurate and more sensitive diagnostic test to identify also those with a very low bacterial load. So, and really to end TB, a fast-active case finding strategy is needed to initiate appropriate treatment as early as possible, as well as to limit the spread of disease. We made some good progress so far, but to achieve our global goals, we are not here yet. We have still a big gap, as we learned from the Professor Ramon, between TB incidents as well as notified TB cases. Today, we are talking globally about 36 new TB cases, which remained unnotified, whereas the global TB treatment success rate is about 82% when we are linking the patients to appropriate care. So what does it mean? That today, in particular in the COVID era, fast access to test results is critical, and we should leverage accurate diagnosis to reach the right people at the right place, ideally with the engagement of the private sector, and to link those to appropriate care and treatment initiation to limit the spread of infection. In 2010, Cepheid stepped in with the GeneXpert MTBRIF testing, and we received WHO endorsement for this. So right after this, here you can see an overview about the WHO recommendations showing up, calling for a rapid diagnostic test on a PCR diagnosis to diagnose persons with signs or symptoms of TB, to make sure we are identifying those who are at risk for transmitting disease as early as possible, as well as to initiate the right care and treatment regimens for those people. So what was the first cartridge? We made a complex PCR technique available in a single cartridge, which allows simultaneous detection of MTB and rifampicin resistance. As you're all aware, it came with onboard controls for each individual sample to check if the PCR reagents are okay with the probe check control, as well as if the specimen processing inside of the cartridge worked well with the specimen processing control. It gave results in less than 2.5 hours, and came in a closed cartridge system to minimize the risk of contamination, gives on-demand results 24 hours, 7 days a week on a random, accessible, and scalable platform, which allows centralized lab testing, as well as gives the same laboratory results in a decentralized setting. So what you can see here, the growing impact of the MTBRIF assay after implementation. Overall, we could see with the XPERT test, we increased the number of bacteriologically confirmed cases. We increased the rifampicin resistance TB case detection rate, and we also could observe the reduction of time to treatment initiation, which is really a key element for appropriate care and also helps to engage the patient more with the treatment regimen. And also we could see the reduction of loss to follow-up. Also, with the appropriate diagnosis, with an accurate frontline diagnosis, we could observe that we could reduce the number of empirical treatment decisions all over the globe. So, but what is new? In 2017, the WHO Technical Consolidation Group published the first technical review of the MTBRIF Ultra cartridge. So, and the WHO recommended the use of the next generation GeneXpert cartridge as a replacement of the MTBRIF cartridge. So the TG recognized that Ultra has a significant higher sensitivity in MTBRIF than MTBRIF, in particular in those who are in need, who have a very low bacterial load, who are smear negative but culture positive. in particular those from HIV-infected patients or pediatric patients. Also, the TGE reported that the performance of Ultra to detect RIF resistance is at least as good in regards to the accuracy. So the group agreed that the greatest benefit, as I mentioned before, was the increased yield for the detection of MTB in smear-negative culture-positive specimens. So let's take a little look on the intended use of MTB-RIF Ultra as a recap. So the MTB-RIF Ultra assay is a PCR-based assay. It is CE-IVD validated for unprocessed sputum samples and concentrated sediments. And it's intended to use for specimen for patients for whom there's a clinical suspicion of TB and who have not received anti-TB treatment. This is quite important for us to keep in mind because the assay can just detect MTB DNA, but the assay cannot say it's DNA from a dead bacilli or from a bacilli which is alive. And then it's always when you're talking about such a sensitive assay, which is really coming in the range of culture in regards to the limit of detection, it's quite important that you don't look isolated on the MTB-RIF Ultra result. Always use it in conjunction with the clinical picture of the patient as well as other laboratory findings to make sure you're giving really the best insights on a patient-centered care. I don't want to talk about what is similar between the old and the new version. It's the same easy to use workflow, but what is different? We use different targets to increase the performance of, or to increase the sensitivity of the assay to for MTB complex detection by adding the insertion sequences IS-1081 as well as IS-6110, which are multi-copy targets to a single copy target to RPOV to determine rifampicin resistance. We also increased the reaction tube size and we significantly lowered the limit of detection from 131 CFU down to 12 CFU per ml. Also, we reduced significantly the time to result down to 80 minutes, which allows to free up capacity on the instruments to allow also further integrated testing for other pathogens or viruses, as well as also to allow broader decentralization, because a rapid result is truly needed when we talk about true point of care setting. As a little recap, here you can see the overview of the first external evaluation of the MTB-RIF Ultra cartridge, and this study shows that the assay is significantly better in regards to the detection of patients with a very low bacterial load, and also provides more reliable results in the rifampicin resistance detection. Let's talk a little bit about the why. What is the benefit for the patient and the diagnosis when we are using MTB-RIF Ultra? As I said, the limit of detection is lower, which comes with an increase of sensitivity, and means you will also detect MTB complex in those patients with a very low bacterial load. With the MTB-RIF test, we had some challenges in accurate detection of so-called silent mutations in the codon 533. Silent mutations in 513 and 514. These were reported as false positive results in the MTB-RIF assay. But in the MTB-RIF Ultra assay, we used a different technique, mild curve assessment, as well as sloppy molecular beacons, which are allowing the assay to detect these mutations in 513 and 514 as silent mutations and reporting them out as RIF sensitive, which is quite important to determine and to determine RIF resistance accurately and to initiate drug-resistant treatment regimes just in those of need and avoid overtreating. So we have a significant better capacity to detect heteroresistance, and the assay comes with a high specificity, and it's negative for NTMs, gram-positive bacteria, and shows no cross-reactivity from bacteria from the lower or upper respiratory tract. So when I talked last time already and did a deep dive overview, I showed the group this result interpretation scheme. The MTBRIF Ultra also comes on semi-quantitative levels, like high, medium, low, and very low, like MTBRIF, followed by a MELT curve analysis to give information about RIF resistance determination. But what is new, and this is something I would like to dig a little bit deeper into, is the so-called MTB trace detected callout. It means when you have you have the insertion sequences, the multi-copy target confirmed and positive, the software is looking, okay, how is the RPOB, the single copy target, amplified? Yes or no? And in case it's not amplified, or just 0 to 1 probes reporting a positive signal, it means the bacterial load in the sample is too low to determine RIF resistance. And this gives you information, or the report out is MTB trace detected. There are traces of MTB in your sample, right? But the bacilli load is too low to determine RIF resistance. So you always have a RIF resistance indeterminate result. What does it mean in clinical practice? A trace result means that you have in your clinical sample low levels of MTB that are detected, but you have no information about the RIF resistance status of the strain. How is it occurs? It's the increased sensitivity of the assay was driven by adding multi-copy targets, the insertion sequences 6110 as well as 1081. Multi-copy targets have a higher probability to be amplified because there are multiple of them on the MTB complex genome, in contrast to a single copy target which was used in MTBRIF just to detect RPOB. I said already that the shorter time to result led to an added capacity to run more tests for TB, also for other GeneXpert-based tests on the same instrument. But in sweet and short, what does all these improvements mean for us and for the user and for the patient in the end of the day? You have a faster time to result. It means a faster detection of drug-sensitive and drug-resistant TB cases to improve treatment initiation. You have also allows a higher throughput per system, leading to an increased system capacity of the existing placements already. And you also have the opportunity to leverage existing systems to expand testing to other diseases because you have a free up capacity. And also the faster time to result helps to reduce the diagnostic delay for the patient, and helps also to link to a shorter time point to appropriate care. The improved specificity for RIF resistance means that with Ultra we have the ability to differentiate silent mutations and to detect RIF mutations and mixed infections, which means more appropriate patient management and improved outcomes. And we're really getting better information about drug-resistant TB and whom to link to drug-resistant regimens. So it comes with the same easy-to-use sample prep workflow. It means no end-user training is required. And the increased sensitivity of the assay helps us to improve the identification of TB in suspected patients with a very low bacterial load, and leading to improved patient outcome because it's earlier linked to care and gives an enhanced TB detection, help us to reduce the transmission to closer contacts, and also leads to fewer culture confirmations. So what are the lessons learned I'm happy to share here is the implementation guide. Most of the countries who are in the testing phase or already implemented routinely MTBRIF Ultra used the implementation guideline from the Global Laboratory Initiative. So this document includes information. It's really comprehensive. It includes information about WHO statements on the assay and considerations for the implementation on a country level. It gives information on the compositions, roles, and responsibility of a transition team. Because basically, you're not only changing something on the lab side, you're also, in particular, looking on the trace results. You need to engage, have a really open communication, drive an open communication from the lab as well as to the clinical end to make sure you are delivering patient-centered care, as well as to make sure you're putting the clinical picture together with the laboratory result to give the appropriate anamnese to your patient. Also, it gives information about how to update national diagnostic algorithms and guidelines, gives information about sustainable analysis of the network, also has information about the operational plan and budgetary considerations for the transition. The MTBRIF Ultra test comes at the same cost like the MTBRIF test, but in particular, when you have a more sensitive test, the assumption is, and the guidance is really to go for more and more frontline testing for a broader scale up of the assay. It also has information on clinical procedures, software requirements, recording and reporting. And also, when you need help and there's anything, Cepheid could support you from the consortium side, as well as also to convert your MTBRIF base to MTBRIF Ultra. We are more than happy to provide timely advice, technical support in country, and if needed on a remote basis to all countries requesting Ultra. We have a very strong team inside, and this is what also other countries use, is to drive a train-the-trainer approach. And this is very helpful, in particular when you're going to a new technique. We are very open to communicate all relevant information on the viability of MTBRIF and Ultra cartridges to our users and to the programs, of course, supporting to provide the correct ordering information and expiration dates in a timely manner. So whenever there's something, we are more than happy as a Cepheid team to support you. Also, we are more than happy to try to help you to make sure you will have the right assay definition files in place, as well as the Ultra product inserts, which is in particular required when you have an accredited and audited laboratory, to make sure you have all documentations in hand for an easy scale-up. Also, we are providing centralized testing of trainers and remote training via webinars. So please just feel free to reach out to us when there's anything on this level. We are more than happy to help you. So also the GLI guide gives insights on the assay performance takeaways. It has, in sweet and short, the sensitivity of Ultra was 5% higher than for MTBRIF, but the specificity was a little bit lower, in particular on a high burden setting. This was predominantly driven by the fact that, as I explained initially, that in particular when you have a patient with a TB history, the bugs are not disappearing from the body, and quite frequently you will find them more than 7 years in the body. And that means the assay, which is so sensitive, will also detect bacilli DNA and gives a positive MTB trace detected call out, even if there's no active TB anymore. The GLI also highlighted the increased sensitivity, in particular in SME-negative patients, and and also reported a specificity decrease, which was significantly lower in patients with no TB history. So here's a very good country experience I wanted to share with you, in particular focusing on the trace detection, because I saw also in the pilot settings in the Philippines, you had about 1 to up to 2% of trace results. And this is similar to the experience from South Africa, which was shared in end of 2018. In total, to this time, they did about 1.4 million tests, and they had close to 2% of MTB trace detected callouts. About 30% of them were culture positive. So it means these are cases were missed with the old assay, but with the Ultra test, these had been detected, which is a great achievement and very helpful for the appropriate care. What they did in South Africa, they used MTB trace detected results from HIV positives and reported them as MTB positive with RIF resistance indeterminate, and requesting and giving from the lab side to the clinician guidance to request further drug resistance confirmation. And in case when a trace result was not from an HIV positive group, the second MTB Ultra test was done. And then the result is again MTB trace. It means the laboratory reported to the clinician, this patient requires further clinical assessment, and to do a deep dive and also look on the other tools, on the chest X-ray, on the clinical examination to understand, okay, if this is active TB or not. So I think the lesson learned is really strengthening the collaboration between lab as well as clinician side to make sure you will have the right results, interpretation of the trace results. And in South Africa, they treated those patients with no HIV background as MTB positive, and in case the patient had no no TB history. Overall, for RSA, they could see that MTBRAF ultra represented a gain of close to 7% sensitivity increasement overall, in particular in smear negatives, like reported from the FIND evaluation, and a slight loss of 3.2% on the specificity side, which came mainly driven by the fact you have TB patients or patients with a TB history enrolled, and they had reported out trace codes. So looking on the total number, here you can see on the pyramid just the little tip of it, about 2% were MTB trace detected callouts, and close to 40% of them were reported with smear positive result or cultural result. And this means those are the cases out of the 2% which have been missed with the old assay. And I think this is a really, really great achievement looking on the technology. Close to 70% of them were reported with culture positive result, were reported with culture result, and close to 35% were reported with culture positive results. And I believe the take home really is to, when you implement Ultra and you scale up more rapidly, make sure that you're encouraging your laboratory to collaborate with the clinicians to build the right diagnosis based in particular on the laboratory result, in particular for MTB trace results, to make sure you will give some guidance which is really associated to the background of the patient. And that MTB trace detected callout is a valid laboratory result. That's a good result. So there should be no fear from the laboratory side to report such a result. Here in this document, it's a summary of the key documents from WHO, from FIND, some key publications, which are also going to be helpful for the implementation. Yeah, and I would like to thank you for your attention, and I'm happy to take questions.
Thank you very much, Inês, for that relevant information on GeneXpert platform and also updates to improve TB detection. May I now request our speakers to please turn on your videos for the gallery. We would like to thank our speakers for answering all the questions most of the questions in the Q&A box. There are several questions about specimen referral, infection control. We also have questions about the GeneXpert machines, how to access the tests. And also there are very interesting questions for you, Inês, and I hope that you will be able to still continue answering them this afternoon, because this webinar will, the launching will actually be after our webinar. So Dr. Garfin also answered the targets that we need to achieve to end TB by 2035. And we have a colleague who posted the link to the TB facilities, including the TB laboratories in the Philippines. Unfortunately, we do not have enough time for open forum. There are more questions, and I hope that our speakers can continue to answer them in the Q&A box. Nevertheless, we had a very productive webinar today. We would like to thank our speakers for sharing their time and expertise with us today. We definitely learned a lot from your discussions. We were able to tackle some questions from the audience, but unfortunately, we do not have enough time to answer all of them. Our organizers will email available slides and references relevant to this webinar to all registered participants. Once again, I am Dr. Janice Kawili, and in behalf of the organizers of this webinar, I would like to thank all of our participants today. We will move on to the next session on the launching of the revised Philippine Strategic TB Elimination Plan, or PhilSTEP, for 2020 to 2023, the latest NTP Manual of Procedures, that's the 6th edition, and the TB-Free PH campaign of the National TB Health Promotion and Communication Strategy. I now turn over the microphone to our next moderator, Brix Eco Jr. Thank you very much, and good afternoon.
Thank you very much, Dr. Janice.
Thank you.
And good afternoon. For many of us today, we have relied heavily on the internet and social media for news, entertainment.
Natin 2040. However, the COVID-19 pandemic has greatly affected the gains we achieved in TB elimination. Between February to March, case notification dropped by as much as 20%, and TB services will continue to be hindered if we do not step up the needed resources and the commitment. We have a lot of work to do. More than 1 million Filipinos have active TB, and about 70 people die of TB every day. Winning the fight against TB requires collective resources, technical expertise, and close collaboration of a wide range of partners, many of whom are here with us today. The U.S. government, through USAID, supports the Philippine government in continuing the work to control and eliminate TB in the country through its Global Accelerator model to end TB. USAID has provided about 2.9 billion pesos, or $60 million, in the past 5 years to support the Department of Health's TB elimination program. USAID will continue to work closely with key partners to dramatically scale up TB prevention, care, and treatment interventions. I am happy to announce that USAID has just developed the TB roadmap to support the Department of Health's efforts to meet its UN General Assembly's commitment to end TB in the Philippines. USAID congratulates the Department of Health National TB Program in completing important documents that will guide the Philippines in its efforts to reduce the incidence and mortality of TB. The Philippine Strategic TB Elimination Plan, or PhilSTEP, the 6th edition of the Manual of Procedures, MOP, and the hashtag TB-Free Philippines communication strategies are now in the process of being disseminated and rolled out in collaboration with many partners and stakeholders. So let us bring our key messages to reach, treat, and prevent TB to all communities. The updated PhilSTEP and the MOP adopt globally recognized standards in TB care that are focused and evidence-based, ensuring that effectiveness and efficiency are achieved along the TB cascade of care. The U.S. government greatly values our strong partnerships with the people of the Philippines. We believe that this launch is another important milestone to accelerate our efforts to reach every person with TB, cure those in need of treatment, and prevent the spread of disease and new infections. So, salamat po. Thank you.
Thank you very much, Dr. Michelle Lang Ali. And indeed, the USAID and other development agencies are important partners in this journey to achieving a TB-free Philippines. This is a journey we all make for and with our fellow Filipinos affected by TB, like Ms. Louie Zepeda-Teng. Because of TB, Louie Zepeda-Teng lost her sight. Because of TB, she found her vision. Louie now leads an organization of TB patients and survivors who yearn to be seen and heard. Let us now hear the story of Louie.
Thanks, Brix. Can you hear me?
Yes, I can hear you.
Okay, thank you. Good afternoon, everyone. So thank you very much for the chance to share my story, which happened 13 years ago. I was a young architect then with big dreams and plans, but I got sick of tuberculosis meningitis. It's an extrapulmonary condition. and I experienced 3 confinements, couple of wrong diagnoses, and my family really experienced a catastrophic cost. Thankfully, I was referred to Tropical Disease Foundation, which was a grant recipient of the Global Fund that year. I was fortunate to be observed by the owner of Tropical Disease Foundation, Dr. Thelma Tupasi, who has left us already last year. And with the help of her compassionate team, I survived. I was the first MDR treatment that was successful, and if I'm not mistaken, not just in the Philippines, but in the world. And they helped me deal with all of the side effects. I had a mild stroke. My half left body was paralyzed. I had Parkinson's syndrome, hypothyroidism, partial paralysis, and of course, severe depression, which was more than 7 months. And of course, the total blindness really made me surrender. Imagine a professional architect losing her vision. It's like 5 years of my education to trash. And at that time, there was no support to address catastrophic costs. Peer support was still ad hoc. The person-centered care was still on its early stages. And so was the ADSM. ADSM was not yet formulated by that time by WHO. So prevention for disabilities, like what happened to me, is not an option. Like many other persons affected with TB, I had to find the strength to live and move on with my life. I had a chance to work at WHO headquarters in Switzerland after I took a scholarship for public policy. And there, I saw the global burden of TB. And this was just 3 years after my treatment. I had to use it as my antidepressant. And this helped me see how my voice can help raise the alarm about TB in the Philippines. Today, I'm very fortunate to be entrusted by an international network called TB People Global. I found these colleagues of mine back in 2013 during the Paris Union Assembly, and they entrusted me to do the same advocacy I'm doing internationally in my own country. And this is to organize a national chapter called TB People Philippines. I registered it early this year before the COVID pandemic. We help the survivors and patients with their non-medical concerns, like socio-economic legal protection. Despite the 13 years of searching in the dark, I now have a clearer vision as a TB survivor and advocate, which is I plan to keep everyone informed and help design healthier lives for all of those people affected with TB. So thank you very much for seeing us and listening to us. Back to you, Sir Briggs.
Thank you, Louis, and to all persons with TB who are with us this afternoon. DOH hears you. DOH sees you. DOH thinks of you. And DOH cares for you. Here to share how DOH plans to care for persons with TB, please welcome the Program Manager of the National TB Control Program, Dr. Anna Marie Selena Garfin.
Thank you, Briggs. Good afternoon, everyone. Can you hear me?
Yes, Dr. Celine, we can hear you.
Thank you. So one of the best practices of the TB program is having a strategic plan that will be the roadmap in our fight against tuberculosis. It was October of last year when the program was joined by international and local experts, implementers, and patients to review the status of our TB elimination efforts. The joint program review provided us with evidence on the achievements that we can build on and the challenges to address across the cascade of care. Supported by this review, as well as other evidences available at that time, the program, in consultation with key stakeholders and partners, set the course on how we move forward in the next 4 years. But first, allow me to recognize the contribution of the following partners in the development of this document: the Global Fund to Fight AIDS, TB, and Malaria through the Philippine Business for Social Progress, United States Agency for International Development and its implementing partners, World Health Organization, Philippine Coalition Against Tuberculosis, professional societies, other government agencies, the local government units, and patient groups. With this plan, we are committing the following for the next 4 years. First, we want to decrease the number of TB deaths by 15%, decrease the TB incidence rate by 12%, reduce catastrophic costs incurred by TB-affected households to zero, and we want a more responsive health services with 90% of our clients being satisfied with the TB services through the patient-centered care approach. Our objectives are screen patients not just with symptoms, but maximizing the use of chest X-ray for screening. Second, test patients with a shift from microscopy to rapid diagnostic tests, such as GeneXpert. So this is free on top of the other services that the TB will provide. And this is true for the public sector. Treat all diagnosed TB patients and ensure completion of treatment and prevent TB. We should turn off the tap to stop the spread of TB. So let us not forget the prevention component of the cascade of care. Our strategies are focused on 4 major steps in the cascade of care. There are 14 strategies on how we will maximize provision of patient-centered care, but it does not mean that we don't recognize the important role of health systems in achieving our objectives. Our plan recognizes important cross-cutting health system issues that will determine success across the cascade of care. So this includes ensuring adequate financing, so we need our budget, human resources for health, efficient procurement and supply chain management, a reliable information system, and definitely private sector and civil society engagement. So it is a multi-sectoral approach in fighting tuberculosis. The strategies of the plan will focus on the patient-centered care approach, and that would mean implementation of patient-centered TB care packages, adoption of home and community-based treatment, establishment of patient support groups and treatment supporters, development and implementation of reliable reporting system, use of shorter all-oral regimens, and implementation of novel tools. So the next slide will show to us the framework of the updated PhilStep. And this is guided by our vision of a TB-free Philippines and anchored on the cascade of patient care. With the COVID-19 pandemic, an NTP adaptive plan have been developed. This plan will be issued as an administrative order and will be an addendum to this document. So friends, partners, colleagues, and most especially the people living with the disease, this is our 2020-2023 updated Philippine Strategic TB Elimination Plan Phase 1. Thank you.
Thank you very much, Dr. Celine. And speaking of caring for persons with TB, meet Malaya. In 2012, Malaya was diagnosed with drug-susceptible TB. She took 3 tablets a day for 6 months, and she spent almost 10,000 on medicines for 6 months. She did not know that TB drugs were free in public hospitals and health centers. After 2 months of treatment, she tested negative for TB and stopped her treatment. Is Malaya truly TB-free? If Malaya were to come to your consultation, what advice would you give to her? Please welcome the NTP Nurse Coordinator of the Center for Health Development in Central Luzon, Ms. Jeliza Jeng Resede. Ma'am Jeng, magandang hapon.
Thank you, Brix. Good afternoon. Can you hear me?
Yes, I can hear you po. We can hear you.
Okay. So, good afternoon. I'm Jeng Rasede, Regional TB Program Nurse Coordinator. If Malaya were our patient, let's say in our private clinic, we would have advised her to go to a public health facility providing TB services where she can get free anti-TB drugs, have her smear microscopy follow-up on the second, fifth, and sixth month of treatment for free, and choose the type of care that she wants during the entire duration of treatment, such as home-based treatment with treatment supporter or digital adherence tool to monitor her clinical status while still having her regular follow-up checkup to us or to our private clinic. And then we will notify the case of Malaya to DOH through the Integrated Tuberculosis Information System, which is a very user-friendly system. You see, this confusion can now be easily addressed if we refer to the National TB Program Manual of Procedure 6th edition, which is applicable to both public and private sector. With a handy pocket guide produced by DOH and USAID's TB Innovations and Health System Strengthening, we can quickly and easily find the right answers and information. In the past, we have looked at patients as mere recipients of our services, but in these new policies and procedures, we treat patients as active partners in healthcare, capable of making well-informed and appropriate decisions for prompt diagnosis and effective treatment. We emphasize this in the revised MOP as it is a priority program policy that encompasses all technical procedures on screening, diagnosis, treatment, and prevention. Also included in the MOP are the mainstreaming of X-ray as screening tool and the adoption of a new rapid diagnostic tool such as Expert MTB RIF test with better accuracy to detect TB and the additional advantage of detecting drug resistance. We also have new regimens for drug-resistant TB without the use of painful injectables. The approach to prevention by treating latent TB infection has also been expanded. All of this for our TB patients and Filipino citizens. Thank you. Back to you, Sir Breaks.
Thank you, Ms. Jeng. Now, we have the plan, the procedures, and also the promotion tools to educate and convince our fellow Filipinos to seek proper health care. And to introduce the communication tools that will soon be available, please welcome one of the key people who are instrumental to the development of the hashtag TB3PH communication strategy. She is the Chief of the External and Media Relations Division of the Department of Health, Health Promotion Bureau. Let's welcome Ms. Arlene Arbas.
Thank you, Briggs. Good afternoon to all our partners and participants. Let me start by introducing Ms. Donna Ramos from Cavite. Her brother Dennis, who lives in Tondo, was diagnosed with DSTB before the COVID-19 quarantine. He did not know how to start his treatment. Donna found the answer on our hashtag TB3PH Facebook. Through hashtag TB3PH, her brother was able to continue his treatment during this quarantine period. She has this to say, "I am satisfied with this group. From the start of the lockdown, our TB patient was problematic with his medicines. Especially now, we need to treasure every single centavo. I also lost the opportunity to help our patient with this medicine. Till came hashtag TB3PH. They helped me how to get the supply. I am thankful. More power and hope you can help many others. Sincerely, Dons Ramos." This is the kind of response we intend to achieve at a personal level from persons affected by TB. But in order to connect with Filipinos like Donna and her brother, we also need to create an enabling environment, report about our resilience, and build trust in our providers. This is what hashtag TB3PH is all about. From the Health Promotion Bureau and our development partners, we will be rolling out soon different communication packages to our decision makers, health workers, allies, and persons directly affected by TB like Donna and her brother. It's a challenging task, but it is a challenge you are willing to take on and carry out for a healthy Pilipinas, for a TB-free me, TB-free family, TB-free community, and TB-free country. Thank you very much.
Thank you very much, Miss Arlene. And Miss Arlene, at sa mga nakikinig o nanonood sa atin ngayon, kapamilya na po natin ang ating kapusong si Mr. Alden Richards. Ayun. And as part of the NTB campaign, once again, please welcome the Asia's multimedia star, Mr. Alden Richards.
Hello everyone, I would like to express my gratitude to USAID for choosing me as their #NTB ambassador. I'm really honored to be part of this public awareness campaign about tuberculosis, especially in these challenging times. I'm really grateful and glad that I will be able to support TB-free PH, encourage health-seeking behavior, and reduce the stigma of this disease. Watch out for our public service announcements on TV, theaters, billboards, and social media platforms. Thanks everyone, and be safe.
All right, so thank you very much, Mr. Alden Richards. And for the mentioned communication packages, please visit the ntp.doh.gov.ph to download these tools and materials. And
Hello
as Ms.
everyone,
Allen mentioned, an enabling environment is needed to reach Filipinos with TB. Moving on, the building block or foundation of that kind of environment was first planted when Congresswoman Angelina Tan of the Quezon District authored what came to be known as the National TB Elimination Act of 2016. Once again, let us hear from Congresswoman Angelina Tan.
Good afternoon. It is a great pleasure to be here to join you in the launching of the PhilSTEP and MOP, which I see as a continuing collective efforts of various agencies of government, the private sector, and civil society organizations to end TB even amid COVID-19 pandemic. I believe your theme for this occasion is spot on, tuloy ang buhay, or we move on, because really we have no other choice but to march on and advance to carry out our mission of eradicating tuberculosis, not only despite of, but because of COVID-19. We are all aware that long quarantine measures have placed severe limitations on TB diagnostic, treatment, and prevention services, which is expected to increase the annual number of cases and deaths over the next 5 years. At least 5 years of progress towards TB elimination could be lost according to some estimates. That is why the National TB Program needs to be actively engaged in ensuring an effective and rapid response to COVID-19 while ensuring that TB services are maintained. The government is steadfastly committed to a vision of a TB-free world, and towards this end, we pledge to treat over 2 million Filipinos with TB in the next 5 years by accelerating efforts to improve access to rapid TB diagnostic tools, introduce new TB regimens or treatment regimens, enhance the logistics management system, adapt cutting-edge digital tools, and guarantee adequate and competent health human resources. This commitment was made clear during the United Nations High-Level Meeting on TB, where we have pledged to ensure adequate social protection measures for our indigent TB patients through multi-sectoral approach with engagement of other government agencies and private sector and other stakeholders, accelerate efforts to improve access to rapid TB diagnostic tools, introduce new TB treatment regimens, enhance adequate and competent health human resources, ensure better health outcomes, a more responsive health system, and a more equitable healthcare financing, and forge partnerships in the areas of effective referral system development to ensure continuum of care, prevent discrimination, and development of drug resistance and TB research networks, establishment, and expansion. Unfortunately, out of nowhere, COVID-19 came upon us, derailing many government programs, including health programs such as TB and, of course, universal health care. These are bumps along the way. We are all certain of that. The road to a world without TB has always been rough, more so now that we have this pandemic, but our commitment remains strong and persevering. In the House of Representatives, we have already passed bill that will calibrate the landmark TB law by introducing important amendments in response to the country's commitments to the UN high-level meeting. We have deemed the political declaration on the fight against tuberculosis, which was endorsed at the UN high-level meeting on TB as a compelling reason to strengthen the Philippine TB law. This proposal features provisions on TB rights and responsibilities, corporate social responsibility to encourage business corporations to contribute in the ongoing efforts to reduce incidence of TB in the country, convergence of services to address the problem of indirect costs or borne out of accessing TB treatment, including transportation, accommodation, or halfway house and meals, among others. TB strategic plan for local government units, integration of TB services into established service delivery networks or local health referral system, and inclusion of TB DOTS treatment as one of the requirements for the conditional cash transfer program. Also included are provisions for personal complement, alternative financing schemes, and other sources of funds in order to ensure sufficient and sustainable financing for the country's commitment to end the TB epidemic by 2030. Financing is what I really see as a fundamental problem in our fight against TB, considering that our budget or TB budget is not making a headway even with the enactment of Republic Act 10767. So I thought of including the mandatory appropriations provision in the TB law amendment to ward off the issue of absorptive capacity of health department and ensure sufficient and sustainable financial support program or support to end TB epidemic, particularly the development of the National Strategic Program to locate and treat over 2 million Filipinos inflicted with TB in the next 5 years. More than commitment, I believe we need to do some real action. More than commitment, we need to collectively persevere in the great cause of ending tuberculosis. As I bring this meeting to a close, allow me to assure you that TB elimination remains to be among the government's health legislative agenda, and we will continue to find ways to honor our commitment before the family of nations to end TB in our lifetime. Let me congratulate the DOH and all those individuals and organizations who put in their efforts in the crafting of the Field Step and MOP, which will serve as our game plan for the next several years and accomplishing the vision and milestone related to TB elimination. Together, kaya nating tuldukan ang TB. Maraming salamat po. Good day and stay safe.
Thank you very much, Congresswoman Angelina Tan, and we look forward to the passage of the amended TB Elimination Act. Thank you very much to Dr. Garfin, to Ms. Arbas, and Ms. Jeng. Thank you also to Ms. Louie, Malaya, Donna, and Dennis for sharing your stories. Indeed, we now have the plan. We have the processes. We have the passion. It's time. Make TB a priority. Despite the pandemic, we have to find, test, treat, and prevent TB. As we observe the National Lung Month this August with the PhilCat webinar series, we also enjoin you to share on your respective social media these FB posts about critical TB messages. By doing this simple action, we collectively focus on our vision and hold on to our combined strength to reach a TB-free Philippines. And with that, we end today's session and see you again next week on August 27 for the 5th session of the National Lung Month PhilCat webinar series. We will tackle MDR-TB on the recent advances in diagnosis and treatment, so kindly register in advance. All right, so may we also ask you to complete the evaluation form for today's session. Just click on the link that is on the chat box, I guess, And we love to hear from you. For other webinar updates, check out the Facebook page of the Philippine Coalition Against Tuberculosis or PhilCat. Maraming salamat po and see you all next week. Stay safe, stay healthy, stay COVID and TB free. Magandang hapon.